All right, everyone, welcome. Today, we are going on a bit of a tour. You could call it a pathological tour. We're going to explore the lower female genital tract. We'll look at the anatomy and, more importantly, the common diseases that affect it. So, shall we begin?
Okay, so here's our plan for today. First, we'll go back to the very beginning, to embryology, to see how this whole system is formed. Then, we'll tackle the troublemakers, the common infections. After that, our tour proper begins, starting with the vulva, then moving to the vagina, and we'll end at the cervix, a really, really critical zone.
Right. Now, before we jump into all the diseases, all the pathology, we first have to understand the foundation, isn't it? So let's start from the very beginning. How is this system actually built? Let's have a look at the embryological blueprint.
Look at this timeline. It's a very, very precise sequence of events, almost like a beautifully choreographed dance. It all starts around week 4, with these primordial germ cells appearing in the yolk sac. Then, by week 6, these structures called the Mullerian ducts form, and they start growing downwards. And here's the key step. They fuse. This fusion in the middle forms the uterus, the cervix, and the upper part of the vagina. And to finish it all off, the urogenital sinus contributes to form the lower part. A beautiful step-by-step construction.
Okay, so now we know how it's built. Let's talk about what can go wrong. The first major challenge this system faces, infections. And some of these, believe me, can have very, very serious consequences.
So who are the common culprits? Well, here's a list of the usual suspects. You have your viruses, like herpes, and, of course, the big one, HPV, human papillomavirus, which we'll be talking a lot more about. Then there's fungi, like Candida, protozoa like Trichomonas, and a whole host of bacteria. Pay special attention to these two, gonorrhea and chlamydia, because they are notorious for causing major problems like infertility. It's quite a dangerous crowd that.
And this is what we see under the microscope. This is our clue. See this cell right here? Look closely. It's got multiple nuclei all crammed together, and the inside, it has this hazy ground glass appearance. This is the classic signature, the cytopathic effect of a herpes virus infection. It's a textbook sign, very important to remember. Okay, next up, pelvic inflammatory disease, or PID. This is a very, very important topic. PID isn't just one simple infection in one place. No. Think of it as an infection that starts low, down in the vulva or vagina, and then it spreads upwards. It climbs up into the uterus, the fallopian tubes, even the ovaries, causing a lot of damage along the way. It's a major ascending complication. So how does this happen? Well, it begins with an infection down below, say gonorrhea or chlamydia. Then these bugs don't stay put. They ascend. They climb up into the fallopian tubes, causing a nasty inflammation called acute suppurative salpingitis. This can lead to pus accumulation. You get abscesses. But here's the real problem. Even when it heals, it leaves behind scars. And these scars can block the tubes completely, leading to infertility or a life-threatening ectopic pregnancy. So the take-home message is what? Early diagnosis and treatment are everything. You cannot wait.
Okay, our tour begins. First stop is the vulva. Now here, we'll look at a range of things, from relatively simple irritations and inflammation, all the way to 2 very different pathways that can lead to invasive cancer. Now have a look at these 2 pictures side by side. On the left, you have lichen sclerosus. Can you see how the skin, the epidermis, has become really thin and pale? It looks almost like parchment paper. Now look to the right. This is lichen simplex chronicus. It's the exact opposite. The epidermis is very thick. And why? Because of chronic rubbing and scratching. So one thins the skin, the other thickens it. And this is the crucial part, both of these conditions are important because they carry an increased risk of squamous cell carcinoma developing later on.
And this is condyloma acuminatum, what we commonly call genital warts. Under the microscope, it has this very characteristic tree-like papillary architecture. It's caused by low-risk types of HPV, specifically type 6 and 11. Now, listen carefully. These warts themselves are not precancerous, but their presence is a huge red flag. It tells you the patient has an HPV infection, and that means they could also be infected with a high-risk type of HPV. And that is what we really worry about. This is fascinating. You see, for vulvar cancer, there isn't just one way it develops. There are 2 completely different paths. Think of it like 2 different roads leading to the same bad place. The first road is the HPV-associated one. This is linked to high-risk HPV, usually type 16, and we tend to see it in younger women. The other road is completely HPV independent. This one happens in older women, and it's often linked to those chronic inflammatory conditions we just talked about, like lichen sclerosis. So two different stories, two different mechanisms. And here you can see the microscopic difference beautifully. On the left is the HPV-related precursor lesion, what we call classic VIN. Look, the abnormal, immature, dark cells, they're all through the full thickness of the epithelium. It's totally disorganized. Now, on the right is the HPV-independent one, called differentiated VIN or DVIN. See the difference? Here, the bad cells, the atypia, are stuck at the bottom, at the basal layer, while the cells on top are still trying to mature properly. This distinction is absolutely critical for us to make the right diagnosis. Okay, let's continue our tour, moving inwards. Next stop, the vagina. Now, the vagina is actually quite tough. It's pretty resistant to disease. But when problems do arise here, they can be very specific and sometimes very serious. And here again, we see a story of two very different tumors depending on the age. In adults, the most common primary cancer is squamous cell carcinoma. And guess who's behind it? Yes, our old friend, high-risk HPV. But in infants and very young children, we find something totally different, a rare but aggressive tumor called embryonal rhabdomyosarcoma. And this is its characteristic appearance. It has a very special name, sarcoma botryoides. Botryoides literally means bunch of grapes. And you can see exactly why from this picture, can't you? The tumor grows in these fleshy, polypoid masses that look just like a cluster of grapes. When you see this presentation, you have to think of this rare childhood tumor. It's a classic. And now we come to the final and perhaps the most important stop on our tour, the cervix. This area is absolutely critical. Why? Because it's uniquely vulnerable to developing cancer. But, and this is the good news, it's also uniquely accessible for us to screen and therefore prevent that cancer. This makes the cervix a major battleground, but it's a battle we can actually win. Now I want you to pay very close attention to this next concept. If you understand this one thing, you will understand almost everything about cervical pathology. It is called the transformation zone. So what is it? It's simply a place, a junction, where two different types of cells meet. The columnar glandular cells from inside the cervical canal meet the flat squamous cells from the outside. So you have to ask, right? Why all the fuss about this tiny little area? Why do pathologists and gynecologists care so much about this one specific zone? Well, the answer is because this zone is ground zero. This is where the battle happens. The immature squamous cells that live here are the perfect target for high-risk HPV. The virus finds these cells to be the perfect home to set up an infection. And because of this tiny area is precisely where almost all cervical cancers start. And this is the proof. This is the smoking gun we search for when we look at a pap smear. This cell has a special name, a koilocyte. Look at it. The nucleus in the middle is big, dark, and irregular. But the most important feature is the clear area around it, this halo. That perinuclear halo is the classic sign that HPV is inside that cell, hijacking its machinery. This is the cellular hallmark of HPV infection. All right, so let's just quickly summarize the main points for today. First, the genital tract develops through a very precise sequence. Second, you must remember that infections, especially HPV, are at the heart of many of these cancers. Third, vulvar cancer isn't just one disease, it has two distinct pathways. Fourth, the transformation zone of the cervix, that is the absolute key battleground. And finally, our ability to prevent this disease through things like the pap smear is all based on recognizing these microscopic cellular changes. So I will leave you with a final thought. We've seen the pathology, we understand the enemy, we know how these diseases develop. The real challenge for you as future clinicians is this. How do we use this knowledge? How does this change our approach to prevention, to screening, and to public health? That is the question we all need to answer. Think about it. Hello, everyone. Today, we're going to investigate one of the greatest medical success stories of our time. It's a real detective story, you know? We're going to look at a disease that used to be a major killer of women, and we'll figure out exactly how science turned the tables on it. So let's begin. Just look at this number, 75%. That's the huge drop in the death rate from cervical cancer over the last 50 years. I mean, just think about that for a second. A disease that was once at the top of the list has been pushed back, and in a big, big way. So the obvious question is, how? How did we achieve such a massive victory? Well, to get the answer, we have to do two things. First, we need to understand the enemy, the disease itself. And second, we have to look at the absolutely brilliant strategies we came up with to fight it. Believe me, 50 years ago, the story was completely different. Cervical cancer was one of the top causes of cancer death in women. The very fact that today we can call it largely preventable and highly curable, well, that's a huge achievement for prevention and early detection. Now, every good story needs a villain, right? And our story, the main culprit, the mastermind behind cervical cancer, is a virus. Let's introduce the human papillomavirus, or as we all know it, HPV. So what is this HPV exactly? It's a very common group of DNA viruses. Now, the most important thing for you to remember is the difference between high-risk and low-risk types. Low-risk types might cause things like warts. No big deal. But it's the high-risk types, about 15 of them, that we are really worried about, because these are the ones that can lead to cancer. And now this is fascinating. Out of all those high-risk types, just look how dominant two of them are. HPV-16 all by itself is responsible for about 60% of cervical cancers. Add HPV-18 to the mix, and together they cause 70% of all cases. Just two tiny viruses causing most of the problem. Remember this fact, Hanyan. It becomes very important when we talk about prevention later on.
Okay, but here's some good news. Even though this virus is super common, our immune systems are amazing fighters. In 90% of cases, the body just clears the infection on its own, usually within 2 years. So the real danger isn't just getting the virus. The real problem is when a high-risk type decides to stick around and becomes a persistent infection. That's the key word.
So how does this persistent infection actually cause cancer? To find out, we need to zoom in. Let's get our microscopes out and investigate the cellular crime scene to see exactly how this virus hijacks our own cells. This is the location. It's called the squamocolumnar junction of the cervix. I know, it's a technical name, but just think of it as a transition zone where two different types of cells meet. The young, immature cells in this exact spot are especially vulnerable to HPV. This is the virus's front door. So once it's inside, the virus is very clever. It pulls off this hijack using two special proteins, E6 and E7. Think of it like this. Protein E7 cuts the cell's brakes, which is a protein called RB. At the same time, protein E6 gets rid of the cell's security guard, another protein called P53. So with no brakes and no guardian, what happens? The cell's growth just goes completely out of control. Now, this uncontrolled growth doesn't turn into cancer overnight. No, it's a very, very slow process. It can take years, even decades. And because it's so slow, it gives us a window, an opportunity to watch the damage as it happens. So let's look at the stages of these precancerous changes, which we call lesions. We call these changes squamous intraepithelial lesions, or SIL for short. And to keep it simple, pathologists grade them on a two-tier system. Low grade, which is LSIL, and high grade, which is HSIL. This grading is absolutely key for deciding how to treat the patient. First up, let's look at a low-grade lesion, or LSIL. Under the microscope, you can see some early, mild changes in the cells. This just means the virus is active. But here's the important part. Remember how strong our immune system is? Most of these LSILs will actually just go away on their own without any treatment at all. But sometimes the damage gets worse. This is a high-grade lesion, or HSIL. Now you can clearly see the abnormal cells are not just at the bottom layer anymore. They have started to expand upwards into the middle of the tissue. This is a much more serious sign that the cell's growth controls are broken. And here we have the most advanced stage of HSIL. The abnormal cells have now replaced the full thickness of that surface layer. At this point, if you leave it untreated, the risk of this progressing to a real invasive cancer is much, much higher. This is the stage we absolutely want to find and treat. So after seeing that progression, you are probably all wondering, what are the actual odds? What is the real chance that these lesions will go away, or just stay there, or progress to something much more dangerous? Well, the data gives us a very clear picture. For low-grade lesions, LSIL, look at this. 60% go away on their own. That's why we can often just monitor them. But for high-grade lesions, HSIL, it's a different story. 60% will persist, and a critical 10% will progress to cancer. And that 10% risk is exactly why we consider HSIL a true precancerous lesion and we treat. Okay, so we've identified the villain, we know its methods. Now for the hero part of the story. how did we fight back? How did we get that amazing 75% drop in deaths? The answer is two brilliant strategies: detection and prevention. For many, many years, our main weapon of detection has been the Pap test. It's a beautifully simple and effective idea, really. You just collect some cells from that vulnerable transition zone we talked about, and you look at them under a microscope. The goal is to find those abnormal cells long before they become a threat. And this slide shows you exactly what we're looking for. On the left, you see normal, healthy cells, but on the right, just look at the difference. These are cells from a high-grade lesion. Look how huge, dark, and irregular the nuclei are. The Pap test lets us spot these dangerous-looking cells and intervene early. This quote really just says it all, doesn't it? No form of cancer better documents the remarkable benefits of effective prevention and screening. The story of cervical cancer is truly the poster child for how powerful a smart public health strategy can be. But, detection is only half the battle. What if we could stop the infection from ever even happening? Well, that's where our ultimate weapon comes in, the HPV vaccine. This has been a complete game changer. And how effective is it? The results are just stunning. Recent studies are showing an 81% drop in infections with the most dangerous HPV types in vaccinated populations. 81%. We are not just treating the problem, we are preventing it at the source. So in the end, the mystery of the vanishing killer was solved, not by a single silver bullet, but by a powerful combination. First, brilliant science to understand the cause. Second, effective screening to catch the damage early. And third, powerful prevention to stop the virus in the first place. It's a truly remarkable story of how we can win the fight against cancer. Thank you for joining this explainer.
Hello, bacha log. Welcome. Chalo. Today we are going on a tour inside the uterus to understand some very, very important pathology. Now pay very close attention, okay? This is a favorite topic for the examiners, so you don't want to miss a thing. All right, let's start with a classic case. You're in your clinic, and a 58-year-old woman comes in with postmenopausal bleeding. What do? Where does your mind go first? It should go straight to the endometrium. This is the most common presentation, and you absolutely must know what could be causing it.
So, here's our plan for today, a quick roadmap. We'll start with how a patient presents, look at the warning signs, and then dive into the two main types of cancer. Simple and logical, right? Let's get started. Okay, first things first. Let's talk about the very first step on this dangerous path to cancer. It's called endometrial hyperplasia. You can think of it as a big, flashing red light, a major warning sign. So, what exactly is this hyperplasia? Fundamentally, it's just this. There are way too many glands and not enough stroma, the supporting tissue. It's like, imagine a garden that's so overgrown with flowers that you can't even see the soil anymore. That's what's happening here. The gland-to-stroma ratio is totally out of whack. Now, what's causing this crazy overgrowth? What's the main culprit? Listen carefully, you have to remember this. It's prolonged, unopposed estrogen. Estrogen just running wild without any progesterone to keep it in check. And you see this in conditions like obesity, where fat cells are literally converting other hormones into estrogen. Menopause, PCOS, you get the picture.
Okay, now for the really cool part. What's happening at the molecular level? It's all about a gene called PTEN. Think of PTEN as the brake pedal for cell growth. It's a tumor suppressor, right? So what happens when this gene gets knocked out? Well, the brake fails, and a major growth pathway, the PI3K/AKT pathway, goes into overdrive. The cells just start growing and growing completely out of control.
Now look closely at these two pictures. On the left, we have hyperplasia without atypia. See how the glands are all crowded together? But if you zoom in, the cells themselves, they look pretty normal, quite orderly. But now look at the right. This is atypical hyperplasia. Oh man, not only is the architecture a total mess with glands back to back, but the cells themselves look ugly. They're disordered, abnormal, and believe me, this distinction is absolutely critical. So why is that distinction so important? Well, get this. In up to 40% of cases where a biopsy shows atypical hyperplasia, a full-blown carcinoma is already hiding somewhere else in the uterus. 40%! That's a huge number. And that, my friends, is why we take this so seriously. It's not just a warning sign anymore, it's a direct precancerous lesion. All right, so now that we understand hyperplasia, let's follow the path. Let's see how it leads to the most common type of endometrial cancer.
And here it is. This is what it can look like with the naked eye. See that large fungating mass filling up the uterus? This is endometrioid carcinoma, and it is by far the most common type. We're talking about 80 to 85% of all endometrial cancers, so this is the one you're going to see again and again.
So this just puts it all together beautifully, doesn't it? It's a clear, step-by-step story. You start with that unopposed estrogen. That causes the hyperplasia. Then you get that critical PTEN gene mutation. That mutation puts the PI3K/AKT growth pathway into hyperdrive, and bam, you've got carcinoma. It's a very logical, very clear progression.
Okay, so that was path number 1. But now we have to talk about the other path. Path number 2. This one is less common, thank goodness, but it is much, much more aggressive, and it plays by a completely different set of rules.
This slide, bachalog, this table is pure gold for your exams. It lays out the differences so clearly. Look, endometrioid carcinoma, which we just talked about, comes from hyperplasia and is driven by PTEN mutations. But serous carcinoma, totally different story. It arises from an atrophic or thin endometrium. And the key mutation isn't PTN, it's TP53. These are two fundamentally different diseases.
And here's what that serous cancer looks like under the microscope. Just look at it. It's got these finger-like papillary structures, and the cells, my goodness, the cells look really, really bad. Very aggressive. And remember, unlike the other type, this one pops up in a thin, atrophic endometrium. By definition, this is a high-grade, dangerous tumor from the very start.
So for this one, forget about PTN for a second. The main villain in this story is TP53. You know TP53, right? The guardian of the genome? Well, in over 90% of serous carcinomas, that guardian is taken out. This mutation happens early, and it's what drives this cancer's wild, aggressive behavior.
Okay, we've talked a lot about the endometrium, the lining. But to get the full picture of uterine tumors, we need to talk about the muscle wall, the myometrium, and specifically, the most common tumor you'll find there.
And here they are, uterine leiomyomas, or as everyone calls them, fibroids. You are going to see these all the time. I mean, they are incredibly common. They're totally benign tumors of the smooth muscle. And when you cut one open, it has this classic look. See it? Firm, white, and this sort of whorled, swirly pattern.
So the big question is, how do we tell this super common, benign fibroid from its very rare but very malignant cousin, the leiomyosarcoma? Well, for us pathologists, it comes down to 3 key things we look for under the microscope. 1. Atypia. How ugly do the cells look? 2. Mitoses. How fast are the cells dividing? And 3. Necrosis. Is there any dead tissue in the tumor? These 3 features tell us everything.
All right, let's wrap this up. Time for a quick summary of the absolute must-know points. This is what you need to have locked in for your exams, for both your written papers and your Viva.
Just remember these 5 pearls. Number 1, unopposed estrogen is the big driver for hyperplasia and endometrioid cancer. Number 2, atypical hyperplasia is a major red flag with a high risk of a hidden cancer. Number 3, know the 2 pathways. Endometrioid is PTN, serous is TP53. Totally different. Number 4, fibroids are super common and almost always benign. And finally, number 5, the evil twin, leiomyosarcoma, is rare and defined by atypia, mitoses, and necrosis. You know these 5 things, you're golden.
And I'll leave you with one final thought to chew on. You know, understanding all this molecular stuff, the PTN pathway, the TP53 mutations, it's not just to pass exams. This is the future of medicine. I mean, think about it. If we know these 2 cancers are driven by completely different molecular engines, should we really be treating them the same way? The answer is probably no, right? This is where targeted therapy comes in. So think about that. Okay, all the best.
Hello, my dear future doctors, and a very warm welcome to you all. Look, I have a question for you. What if I told you that one of the most confusing, most dreaded topics in pathology could be simplified with just one single framework? Yes, today we are going to decode ovarian tumors, and I promise you, by the end of our session, you will see this topic in a completely new, crystal clear light.
I still remember my student days, yaar. I would look at this long list of names, serous cystadenocarcinoma, immature teratoma, and my head would just start spinning. It feels like you just have to mug up this random list of words for the exam, isn't it? But trust me, there is a secret to cracking this, and it is much, much simpler than you think.
The entire funda, okay? The main concept you need to get is this. Almost every single ovarian tumor you will ever have to know about comes from one of only 3 types of cells inside the ovary. That's it. If you can just remember these 3 families, you have already won half the battle. And here they are, our 3 big families. First, you have tumors from the surface epithelium, which is the layer covering the ovary. Second, we have tumors from the germ cells. These are the precious egg cells. And third, tumors from the sex cord stroma, which are all the supporting tissues. See? Every single tumor we're about to talk about fits so neatly into one of these boxes. Chalo, let's start with the first one. So let's dive into the biggest group, the epithelial tumors. If you are planning to work in gynecology or really any clinical branch, these are the tumors you are going to see most often. They are the most common troublemakers, so please pay very close attention to this section. Now just have a look at these 2 pictures. Can you guess which one is probably more aggressive? On the left, you see the serous carcinoma. It's solid, it's fleshy, it honestly just looks angry, doesn't it? But on the right, the mucinous tumor, well, it's this huge bubbly collection of cysts. So that's your first big clue. The gross appearance itself tells you so much about its personality and its behavior. And listen, these differences are not just some trivia for your Viva. Knowing that serous carcinomas are often bilateral, meaning they are found in both ovaries, that can completely change the surgeon's plan during the operation. Mucinous tumors, on the other hand, are almost never bilateral. If you see them in both ovaries, you have to suspect it's not from the ovary at all, but a metastasis from somewhere else, like the appendix. Okay, so if you remember only one malignant tumor from this entire family, please make it this one, high-grade serous carcinoma. This is the big bad boss of ovarian cancer. And here's a super important update in pathology. For years, we were looking for the fire inside the ovary, but now we know that the spark, it often starts in the fallopian tube, from a tiny little lesion we call a stick. This one fact has totally revolutionized how we think about this disease. So you see, it's actually 2 completely different stories. You have the low-grade cancers, which are like a slow-burning fire. You know, they develop over a long, long time from pre-existing borderline tumors. And then you have the high-grade ones. These are like a wildfire. They start explosively from the fallopian tube, they're driven by TP53 mutations, and they spread like crazy. 2 totally different beasts. All right, moving on to our second family, the germ cell tumors. These tumors arise from the oocytes themselves, and you'll typically find them in younger patients, children and young women. Not only are they clinically very important, but they're also absolutely fascinating, as you are about to see. Just look at this. No, your eyes are not playing tricks on you. That is a ball of hair and greasy, cheesy material, all found inside an ovarian cyst. This, my friends, is a mature cystic teratoma, also called a dermoid cyst. Because it comes from a pluripotent germ cell, it can form literally anything. Skin, hair, bone, cartilage, and yes, sometimes fully formed teeth and even bits of brain tissue. How bizarre is that? So how do we classify them? It's simple. Think of it this way. A mature teratoma, the benign one we just saw, is like a properly built city where all the different tissues are well organized and in their right places. But an immature teratoma, that's like a city under chaotic construction, full of jumbled, primitive embryonic tissues. And it's that chaos that makes it malignant. Okay, everyone, eyes on the screen, please. This is a 5-star must-know image for your practical exams. If the examiner puts this slide under the microscope and you see this very specific structure that looks just like a tiny kidney glomerulus, what are you thinking of? You are looking at a Schiller-Duvall body. And this is pathognomonic. That's a fancy word meaning if you see this, it's a direct ticket to the diagnosis of a yolk sac tumor. And what is the tumor marker? Alpha-fetoprotein, or AFP. Now, why is AFP so important? Because we can measure it in the patient's blood to diagnose the tumor and to track how well the treatment is working. Lock this point in your brain. And that brings us to our third and final family, the sex cord stromal tumors. These tumors come from the supporting tissues of the ovary, the very cells that are supposed to produce hormones. And, well, that is their signature feature. These tumors often make hormones themselves, causing all sorts of clinical effects in the patient. The most important one for you to know here is the granulosa cell tumor. Under the microscope, you'll see these beautiful little rosettes called Call-Exner bodies. Now, what do granulosa cells normally do? They make estrogen.
So these tumors are like little estrogen factories, and all that excess estrogen can cause other problems like endometrial hyperplasia. So if an older woman comes to you with postmenopausal bleeding, you must always keep this tumor in your differential diagnosis.
Now for another classic clinical question, Meigs syndrome. You absolutely positively have to know this famous triad for your exams. It's a benign ovarian fibroma, plus ascites, which is fluid in the abdomen, and a pleural effusion, which is fluid around the lung. You see this triad, you must think of Meigs syndrome. And the most amazing part? You remove the fibroma, and the fluid just magically disappears. So, we've traveled through our 3 big families of ovarian tumors, from the common ones, to the bizarre ones, to the hormonal ones. Now let's bring everything together with one final, high-yield summary slide that will lock these concepts in your mind for good, perfect for that last-minute revision before your exam.
Okay, this is your revision cheat sheet. Just remember it like this. Family number 1, epithelium, the common cancer. Think high-grade serous, the villain from the fallopian tube. Family number 2, germ cell, the weird and the wonderful. Think teratoma, with its hair and teeth. And family number 3, sex cord stroma, the hormone makers. Think granulosa cell tumor, the little estrogen factory. Got it? See? It's simple. So, we've classified all the names, and we've learned the buzzwords for the exams. But always remember, behind every slide, behind every diagnosis, there is a patient story. So the next time you see a pathology report, I want you to ask yourself, what is the story behind this slide? And how can I use this story to help my patient? Because that, my friends, is what makes a good doctor. Thank you for joining me. Study well.
Good morning, students. Welcome. You know, people often say a successful pregnancy is a miracle, and in many ways it is. But as future doctors, you and I know it's also a very delicate biological process, a tightrope walk where things can sometimes go very, very wrong. Today, we are going to talk about these pregnancy pathologies. Understanding these is absolutely crucial because it's about protecting 2 lives, the mother and her child. So let's begin.
Right, so what is on our agenda for today? We'll break it down into 4 main parts. First, we'll look at the very first challenge, implantation. Then, we'll discuss problems with the placenta and the umbilical cord, the baby's lifeline. After that, we tackle a big one, the great preeclampsia puzzle. And finally, we'll examine what happens when the placental tissue itself grows abnormally. Let's get started.
Okay, section 1. You see, a successful pregnancy is all about a very tricky balancing act for the mother's immune system. Think about it, eh? The fetus is genetically half from the father. So to the mother's body, it's like a half foreign guest. A hemiallograft is the proper term. Her body has to learn to tolerate this guest, not attack it. So when this balance fails, or if the implantation happens in the wrong place, that's when we see our first big complication.
And the most dramatic example of a wrong place implantation is an ectopic pregnancy. The definition is very simple. The embryo implants somewhere other than the normal place inside the uterus. And where does this happen most of the time? The fallopian tube. In fact, something like 90% of all ectopic pregnancies, they're tubal. Now look at this slide. This is why an ectopic pregnancy is so dangerous. What you're seeing here is a fallopian tube that has ruptured. This causes hematosalpinx. The tube fills up with blood. But the real danger, the life-threatening danger, is the massive internal bleeding that follows. This is a proper surgical emergency, a picture you should never, ever forget. So you must be wondering, sir, why does this happen? Well, the main culprit, the key factor, is scarring. Anything that damages the delicate inside lining of the fallopian tube can basically trap the fertilized egg. Pelvic inflammatory disease, or PID, is the most common cause. It leads to scarring in almost half the patients. Other things, adhesions from a past surgery, maybe an appendectomy, or conditions like endometriosis. Even an IUD can slightly increase the risk. All right, moving on to our second section. Let's say implantation happens perfectly. Are we out of the woods? Not at all. Later in the pregnancy, big problems can develop with the structures that are keeping the fetus alive, the placenta and the umbilical cord. This is the fetal lifeline, and when that lifeline is under threat, the fetus is under threat. Just look at this image, a true knot in the umbilical cord. This cord is like a highway, isn't it? It's carrying blood, oxygen, nutrients, everything. So tell me, what do you think will happen when this highway gets tied up in a knot and pulled tight? The traffic, the blood flow, it can be severely blocked or even stopped completely.
This is a fetal catastrophe just waiting to happen.
And here we can see the result under the microscope. You see, healthy placental villi should be nice and pink, full of fetal blood vessels, but when that cord is blocked, you get this, avascular villi. See how they are pale, almost ghost-like? It's because they've been starved of blood, and without that blood, there is no nutrient exchange. The lifeline has been cut.
Now, besides the cord, the location of the placenta itself is so important. In placenta previa, it implants too low, covering the cervix. This can cause very bad bleeding, especially later in the pregnancy. But even more dangerous is placenta accreta. Here, the placenta attaches too deeply, right into the muscle of the uterus, because that normal boundary layer is just absent. This is a nightmare because it won't separate after delivery, leading to a massive, life-threatening postpartum hemorrhage.
And now we come to one of the great puzzles in our field, preeclampsia. This is not just some local problem, you understand. No. It starts in the placenta, but it becomes a systemic disease. It affects the mother's entire body, and it creates a true maternal crisis.
To understand just how serious this puzzle is, just look at this number, 50,000. That is the number of mothers who die from preeclampsia and its complications. All over the world, every single year. This is a major, major global health problem.
So what is the core problem? At its heart, it's a plumbing issue, a blood supply issue. In a normal pregnancy, the mother's uterine arteries get remodeled. They become wide-open, low-resistance pipes, designed to flood the placenta with blood. But in preeclampsia, this remodeling fails. The pipes stay narrow and tight. And the result? The placenta is starved of blood, a condition we call placental ischemia.
And this ischemia, it sets off a very dangerous chain reaction. The placenta is starved for oxygen, so it starts releasing these harmful factors into the mother's blood. And what do these factors do? They attack the mother's endothelium, the lining of her blood vessels, all over her body. This widespread damage is what causes the classic signs you must look for: high blood pressure, protein in the urine, and swelling. It's like a small fire in the placenta that causes smoke to fill the entire house.
And if it's not managed, this crisis can get much, much worse. The mother can start having seizures. That is what we call eclampsia. Or she could develop HELLP syndrome, a terrible combination of red blood cell destruction, liver damage, and a very low platelet count. These are the complications we all fear.
In our last section for today, we're talking about something a little different. This is when the placental tissue itself, the trophoblast, begins to grow abnormally. This is a whole spectrum of conditions called gestational trophoblastic disease, and it ranges from benign growths all the way to a very serious cancer.
The most common form you will see is the hydatidiform mole, or what we usually just call a molar pregnancy. What happens here is the chorionic villi, those tiny little branches of the placenta. They become all swollen with fluid, looking like little cysts, and the cells around them just start proliferating like crazy.
This is a beautiful slide, a classic gross microcorrelation for your exams. On the left, you see the uterus is filled with these grape-like structures, Hannah. Now look on the right at the microscope view. That's exactly what those grapes are, massively swollen hydropic villi. This is the classic picture you must remember.
Now, it is extremely important to know that not all moles are the same. We classify them as either complete or partial. A complete mole, it has only paternal DNA, there's no fetus, and it carries about a 2.5% risk of becoming cancer. A partial mole has both maternal and paternal DNA, you might find some fetal tissue, and the cancer risk is very, very low. This difference is vital for how we manage the patient.
And that cancer we are worried about is this fellow, choriocarcinoma. This is a highly malignant tumor of those trophoblastic cells. And while it can happen after any pregnancy, about half of all cases, they follow a complete hydatidiform mole. This is exactly why we monitor these patients so closely after they've had a molar pregnancy.
And this image shows you just how aggressive this cancer can be. It's a bulky, bloody mass that is invading deep into the uterine wall. It looks terrifying, and it is. It loves to spread through the bloodstream, especially to the lungs. But, and listen to this is a very important point, despite how bad it looks, this cancer is remarkably sensitive to chemotherapy. It is one of the great success stories of oncology, actually.
So let's finish with this thought. We've seen today how one single organ, the placenta, can be the site of implantation errors, the source of a systemic maternal disease, and even the origin of a cancer. It is the interface, it is the lifeline, it is the engine of the entire pregnancy.
So the take-home message, the thing you must understand, is that the health of this one organ is fundamentally linked to the health of two patients, the mother and the fetus.